May you hear me?
Yes, we could
Yes.
hear you.
Good morning. It's a very unpleasant and difficult time, but you know, we, we are we are fighting a very difficult uh, battle against the virus. May I have the first slide? No, yes, this is about treatment. We use it's good. We use inhibitors of viral replication, lopinavir and ritonavir. They are antiprotease drugs usually used in HIV patients for HIV virus. And there is an ongoing trial, not yet really started in Italy, or started only in a few centers with remdesivir. Is a nucleotide analog used in Ebola virus and in other RNA viruses, and I think it could be very promising. The important strategy is when you need to use some clues indicating that this pneumonia may be sustained by hyperimmune reaction, and in fact, patients have a two-step profile. Their fever, myalgia, asthenia for 7-10 days, and a subset of them develop respiratory failure 7-10 days later, probably when acquired immunity start to work. And in this context, and also we know that from the laboratory point of view, there is an increase of inflammatory cytokines, mainly interleukin-6, and the use of tocilizumab is a monoclonal antibody against interleukin-6 receptor used in rheumatoid arthritis, was used in China and now in Italy, and we experience with this drug and with preliminary good data. There is an ongoing trial, observational trial, and a phase 2 trial started 1 day ago with this drug. So, and the other big point is, do you use steroids or not? We have some data that are against the use of steroids, but these data are not so strong. And in this context, when we have a rapidly progressive respiratory failure, we tend to use steroids, 30 milligrams twice a day, some methylprednisolone. So this is all about treatment strategy from the clinical point of view.
Okay, so Dr. Chu, I'm going to hand the floor back to you. There's a lot of great questions, so if you want to go ahead.
Yeah, we've had a vibrant discussion during both excellent talks. Thank you both. And I will just begin because we have so many questions. I'll start by asking a question that is on the top of everyone's mind, which is, what have you noticed in general for your patients about the timeline between the onset of symptoms and the need for mechanical ventilation?
So the time that is between the starting of symptoms and the appearance of acute respiratory failure, is it correct?
Yes.
I think that we have, the time is about 10 days after the onset of fever, dry cough, myalgia, and asthenia. So we have a period in which respiratory failure is not present, and it appears later.
Do you use a symptom severity score or other metric for determining how critical a patient is in order to help with triage or to allocate resources?
I will discuss later with two or three slides this question, so I will answer later.
All right. Another question that's been on the top of a lot of people's minds: have you been ventilating more than one patient using the same ventilator? Many people have seen this described, but have no experience.
So I can answer, Venerino, if you want.
Yes, yes, it's up to you.
So we are hearing something about this in the last days. We know that during SARS pandemics, in some setting, someone did it. I think that you can do it with dedicated respiratory circuit, which is not so simple to provide it, but you can do it. But I think that it can be respiratory circuit, which is not. It can be only a problem when you have no more resources. And so, as Emanuele said before, fortunately, we have not this problem yet. We hear that someone is thinking about this, but I have some problem with this, because you have to choose patients who are quite similar in his soma, because I think it's quite difficult to think of ventilating patient of 50 kilograms or 100 kilograms in the same way. And probably if you have to do it, the best option is pressure control ventilation, which is probably less harmful than volume control ventilation if you have two patients ventilated with the same ventilator. But I hope never to do it.
Okay, next question. How are you handling emergent airway management? Specifically, how are you pre-oxygenating given the limitations on flow and concerns over mask leaking? We've had significantly decreased safe apnea times given changes to our airway protocols.
So I think that Giovanni Scognamiglio will speak about this topic later, but we use pre-oxygenation with high flow oxygen, or with a face mask with a reservoir, and we use rapid sequence intubation. But I think that Giovanni will speak about this topic later.
What are the criteria you have used for ECMO candidacy? And how many patients have you placed on ECMO, and how many have survived?
So we haven't placed the patient on ECMO yet. We treat 21 patients. We consider the ECMO for 2 of them, but after the 4th cycle of pronation, their PaO2 VO2 ratio now is over 100 without proning anymore, and with the PEEP level below 15. So I think that you have to consider ECMO for this patient, but you have to be sure to have done everything you can do with your ventilation strategy before to perform it. Another issue for ECMO is veno-arterial ECMO in case of severe myocarditis or in case of cardiac arrest, which is a topic. And I know in another hospital in Italy, they have 2 patients of VA ECMO for this problem of pump failure due to myocarditis and not VV ECMO. Because I think that those lungs are not so difficult to ventilate, and probably this illness will go a little bit better with mechanical ventilation, having a little bit of taking a little bit of time and do everything you can do with mechanical ventilation. But maybe Alessandro Circelli can say something more about ECMO.
Okay, I'm going to end with two questions, each on subspecialty anesthesia. The first about obstetric patients. What is your PPE, personal protective equipment protocol for obstetric patients, specifically those receiving labor epidurals, versus having to convert to general anesthesia during C-section?
So I think that it's better than Vanni Agnoletti will answer this question. If the conversion from anesthesia for local regional anesthesia to general anesthesia is an emergent indication, we use the same issue we use for in-hospital emergency system. So in case of suspected or a certain case of COVID-19, we use all the protection to perform tracheal intubation.
Okay, and then I know that we have more to go, so we'll wrap up now and ask other questions later. But this last question for pediatric patients: is it true that pediatric patients are less affected by COVID-19? Are you routinely testing all pediatric patients, even asymptomatic patients?
No, we are not testing pediatric patients routinely. And it's true that they are significantly less affected, and the disease is quite mild and can be more an enteritis instead of a pulmonary disease. And in fact, the problem for children is that the virus is more frequently found in the feces instead of the nasal swab. So they can be distributors or spread but they are not routinely affected. They are not heavily affected and routinely screened for SARS-CoV-2 so far.